We invite Alicia to discuss a challenging diagnosis, dural tumors. Thank you, Alicia.
My talk will discuss we'll discuss about the differential diagnosis of dural lesion. We know that meningiomas are the most common mass lesion of the dura. However, there are a number of dural lesions that mimics meningioma with considerable different prognosis and management. We also call these lesions meningioma mimics. What is the dimension of the problem? How frequent are meningioma mimics in clinical practice? We know that observing 1,000 of patients with a radiological diagnosis of meningioma that undergo surgery, in the 98% of patients, we have a confirmed diagnosis of meningioma. However, we have 2% of patients in where the diagnosis is a meningioma mimics. In this series, you can see that the more frequent is metastasis from solid tumors, but we can have also other CNS tumors like gliosarcoma or melanoma of the CNS, medulloblastoma. We have not only solid tumors, we can have also granulomatosis diseases like tuberculosis or sarcoidosis, lymphoproliferative disease like CNS lymphoma, or a more rare disease called Rosai-Dorman disease or autoimmune disease. But if meningiomas is the most common dural lesion, what is the imaging? We know that CT scan is the best scan to show bone involvement, in which hyperostosis is the most characteristic sign. However, MRI is the best imaging to demonstrate meningioma, and we have homogeneous enhancing lesion like this, and it's important to note that on T1 we have an isointense lesion with the brain parenchyma, and also on T2. This imaging is related to a mild brain edema that is frequent present. And in Stars and colleagues says to us that we have 5 key images that can help the radiologist to distinguish meningioma mimics. These are These are the aspects on T2, the bone destruction, the leptomeningeal extension, or the abscess of dural tail. The first red flag is the hypointensity on T2. You can see, for example, in these images, the T2 hypointensity, and that indicates an hypercellularity, large areas of calcification, or significant fibrous tissue. In these cases, you can have a diagnosis of fibrous tumors or of CNS lymphoma. On the other hand, you can have a T2 hyperintensity, like in this image, that it reflects a significant water content. And also in this case, we can have a diagnosis of fibrous tumors or of schwannoma. The other red flag is the bone destruction. This is a typical figure. It's very common in metastasis from solid tumors, but we can have also in lymphomas and in fibrous tumors. It's very different to hyperostosis that is typical of meningioma, and it's this sign that you can see for a bone reaction near to the lesion, that is this one. Leptomeningeal extension of the tumor is another red flag. That is the extension, like in this, with the infiltration of the leptomeningeal area. Meningioma generally grow along the dura, infiltrated in a sheet-like manner, and then very different from this one. The diseases that can be associated were normally brain metastasis, but also CNS lymphomas or schwannoma or other fibrous tumors. The absence of dural tail is the last red flag. It's very contradictory because is present in up to 70% of meningiomas, but also meningioma mimics can demonstrate a dural tail in 16% of cases. The radiological signs of aggressiveness like bone invasion or leptomeningeal extension could be also a characteristic of an anaplastic meningioma. However, these signs of aggressiveness are very important both for the radiologist, both for the neurosurgeon, because represent the aggressiveness of the disease. Some examples of these 5 red flags are, for example, this lesion, hypointense in T1. Here, the contrast-enhancing lesion that is very similar to meningioma. However, we haven't a dural tail, and on T2, a clearly hyperintensity images. And this diagnosis was of a dural meningioma. Another examples of the 5 signs is this one. Here in T1, you cannot see the lesion and is typical of meningioma. Here, the contrast enhancing sign that is very similar to meningioma, however, we haven't the dural tail, and on T2, a clearly sign of hypointensity on T2. This diagnosis was a solitary fibrous tumor. However, dural lesion diagnosis is a rough road, also because also in meningioma we have atypical imaging features, like, for example, the presence of an hemorrhage that is very rare, but it could be represented in this manner. Here, the lesion, the blood over here, or with the contrast enhancing lesion, you can see the dural tail and the lesion around the blood, and on T2, the hyperintensity. Another atypical imaging feature is cystic changes that are present up to 20% of meningiomas. You can see here we have a different aspect of cystics. You can see here a small meningioma with a big cystic all around, or lesions like that, in which you can have a cystic all around and meningioma. Another very rare atypical image is a metaplastic change. That is a focal or widespread content of the meningioma. This is a case reported by Roncaroli and colleagues, and here you can see a typical meningioma with the tail. However, we have an hypointensity in T2. This was a lipomatous meningioma. We have not only atypical features, we have only atypical locations like this. This is a paracellular meningioma that is in differential diagnosis with an adenoma. We know that meningioma is supracellular, that has a typical dural tail and hyperostosis and tends to encase vessels. Furthermore, meningioma show very high perfusion rate. Another very, very rare case is intraventricular meningioma. That is something like that. Most common in pediatric meningiomas, and the most common location is the atrium of lateral ventricle. Another atypical location is penile meningioma that is present in 10% of cases, more common thoracic spine, and with highest prevalence in the elderly population. A spectroscopy could help us to distinguish these entities. We know that meningiomas are hypervascular, has higher perfusion values compared with other extraaxial actions. Exception is metastasis from renal carcinoma. Furthermore, meningioma has high values of alanine and NA. Metastases demonstrate typically high lipid and lactate, and solitary fibrous tumor high immunositol. I will show a clinical case that is very representative of this differential diagnosis. This is a man of 69 years old, diabetes and hypercholesterolemia. He demonstrated in August 2023 the appearance of diplopia and headache. On September, he performed a brain CT and a brain MRI. This is the CT scan. You can see the lesion with contrast enhancement, typically contrast enhancing. However, on CT, you can see that we have a clear bone erosion. However, the radiologist described as first hypothesis referred to a meningioma. The brain MRI is this. You have an enhancing lesion here and here, a T2 aspect that is iso-intense with the brain parenchyma. Then the radiologist says to us that was an ambiguous interpretation. However, the first hypothesis was that of meningioma, warranted a neurosurgical evaluation. The biopsy was not performed based on the size of the lesion and on the patient preference. The patient was treated with CyberKnife, 25 gray in 5 fractions. However, some days or weeks after, the patient reported a hard palate lesion. And at the end of November, was an end visit and a biopsy was performed. And the diagnosis was of adenoid cystic carcinoma. Then the patient was referred to our hospital. A total body CT was negative for brain metastasis, for distant metastasis, sorry. This is the aspect of head and neck MRI, and this is very interesting because you can see that this is the small lesion of the palate, and the lesion goes up with the palatine nerve infiltration, giving a continuous lesion with the lesion already known. Then the radiological case was interpreted as the same disease. The patient was then treated with carbon ion radiotherapy, and then few months after, the patient developed liver metastasis and began the first-line treatment with lenvatinib. What are the take-home message? Be aware about meningioma mimics because, as you have seen, they may require different preoperative staging and other treatment strategies. We know that we have 5 easily recognizable key imaging features that can alert the radiologist and consider other differential diagnoses. Furthermore, a complete imaging workup should be performed in patients with atypical lesions, and multidisciplinary rounds are necessary for decision-making in treatment meningioma-like neoplasm. Thank you.
Thank you, Alicia, for this well-illustrated presentation with all this image.
Sorry, Julia, for I'm a medical oncologist, and then sorry if
maybe a question in the audience for Alicia. Otherwise, I'm wondering about, you didn't talk about DOTATOC PET. Sometimes it can be helpful if we are faced to a challenging diagnosis. What are your experience? What would be your advices to run this kind of?
Yes, it could be another diagnostic imaging that it can be useful because, for example, in meningioma, we can have a differential diagnosis, for example, with radionecrosis. And DOTATOC could help us to distinguish meningioma that frequently takes somatostatin receptors positivity, different from, for example, radionecrosis. If we have a JAPT, DOTATOC or gallium-68 could be useful in distinguish meningioma, but not is always present in meningioma, the positivity for somatostatin receptors.
Okay. The other question, any clinical red flag you would pinpoint? Yeah, clinical red flag. I guess when we see a dural lesion in a 20 years old man, it's probably not a meningioma, right?
My patient?
No, your patients in general.
In general?
Yes. When do you request a biopsy, another examination faced to a patient which is young with a dural lesion, for instance?
If the patient is young, we have to consider fibrous lesion probably as the first alert, because they are frequent in younger patients, for example. It's always better to have a biopsy before to treat a patient. This is
That would be the advice for young patients, you mean? It would be your advice for young patients?
Yes, yes.
Okay, makes sense. Yeah. Okay, we move. A question, last question by Johnny.
Just a quick question. It's also on the Dotanok PET, because we have a habit of doing it, and we have almost no negative scans if we do a Dotanok PET. If it's post-operative, then it's good for residual. Either way, I have quite a few patients who have this hyperostosis. And then you ask yourself during the surgery, do we need to drill out this hyperostosis? So I had some patients that had mainly hyperostosis, and then one of the maxillofacial surgeons did a biopsy, and a meningioma came out of it. So she had a swelling in the temporal area. And so if you looked at the CT, the whole sphenoid was really thick, and it became, so she had pressure on the eye because of that, and no lesion intracranially. So the dura was okay. And we ended up doing the Dotanok PET, and it was only within the bone that you could see the positivity. So I had drilled it all out and did a whole reconstruction. And so after that, I started doing the Dotanok PET in a lot of patients, and then saw that the bone was often negative if you have the thickening. But do you have any data on that? Because since that case, I became worried that if you don't drill out what's left in the bone, or that you need some way of determining whether there's some infiltration in the bone or whether it's reactive hyperostosis.
Hyperostosis is more a reaction of the bone, not a real infiltration of the bone. It's a reaction of the bone for the presence of the mass, and not a real infiltration. I don't know if Giulia could add something like that. And we have a real infiltration if we have anaplastic meningiomas, and it's very common to see. However, hyperostosis is not an infiltration. It's logical that it could depend on the patient. Every patient is different from the other. Probably we haven't enough data on Dotatok to have, we have not large series to describe this infiltration in bone.
Yeah, it's reassuring that most of the time, as a general rule, it will be a reactive hyperostosis and not an infiltration.
And so, Dotatok or PET in general is not an anatomical study. Then it's not an anatomical, it's a functional study. Then it's not so clear, no? The area, what is the limiting area of infiltration, yes or not?
Yeah, but if it's in the skull-based area, then you have quite thick bone, and so you can tell whether it's really meningeal or in the bone.
It's useful if it is positive.
What's that? Yeah.
If it's negative.
Yes.
You know, often we have mixed pictures of both hyperostosis and infiltration. When we do target delineation, I think CT will help a lot, because it's completely different. Why hyperostosis is just an enlargement, it is there is no erosion of the bone. With infiltration, we see that the bone is completely different. So probably with MRI, it's more difficult to understand. But with CT, usually we don't target that area. We don't see a lot of relapse. But I understand that this is still, especially for grade 2. For grade 2 meningioma is an issue.
Yeah, because I had a recent case of a patient, like many have, with a small meningioma, coincidental finding. But on the MR, I already saw that it was also at the anterior temporal area, and I saw that the sphenoid was very thickened. So I did the CT scan, and then you see indeed a complete thickening and disproportionate to the size of the meningioma. So I became a bit worried that this would also be complete infiltration. And then we did the Dotatok PET, and it was only the meningeal lesion that was positive and not the rest. So